Hello, class. Our topic for this session is Neoplasia Part 1. Neoplasia is derived from the Greek terms neo and plasma, which would mean new thing formed. Neoplasias would refer to growth of tissues that have exceeded normal cell proliferation, which would mean that they have gone beyond the limits of physiologic growth. Neoplasias would contain or would possess space occupying properties which we would call as tumor. And you have encountered the term tumor before, and this is in the chapter of inflammation pertaining to swelling. But in clinical practice, when we hear the term tumor, this would refer to neoplasias. Neoplasias would exhibit varying degrees of fidelity to the precursors. It means that they can be well differentiated, moderately differentiated, or poorly differentiated depending on their appearance. So they can be relatively mature looking, like that they mimic normal structures, or they can be so primitive that the cell origin cannot be assessed or identified. So there are histologic components that would be seen in the microsections. The stroma pertains to the connective tissue, the blood vessel, and the supporting matrix, where uh, and the parenchyma would refer to the neoplastic cells. So neoplasias are derived from actively proliferating cells. And when they have genetic mutations, the genes that are mutated would regulate cell growth, apoptosis, or DNA repair. So when we are confronted with a tumor, for example, a patient would come to your clinic and then presents with a mass, then this is a very important question that you have to ask yourself. Is it benign or malignant? When we are going to do the histologic result or the histopathologic result for a particular tumor, then we describe it to you using a primary descriptor and secondary descriptors. A primary descriptor would identify the tissue of origin, while the secondary descriptors would identify the architectural pattern. Like if it's papillary, which would mean that they have projections or front-like projections. Medullary, if it has a soft cellular appearance with very little stroma, or it can be desmoplastic, which would mean that there's a lot of stroma, it's dense, and is fibrotic. This particular tabulation is very important. Important in a sense that we'll not only be seeing these terms today as of your as you are listening right now, but you can also encounter these terms in third year, fourth year internship, or in your clinical practice. So let's now look into the nomenclature of tumors, and we look into the tissue of origin. What is that? Is it a primary descriptor or a secondary descriptor? It's a primary descriptor. And then we look into what are the nomenclatures pertaining to benign and malignant tumors. When we are referring to connective tissue, like if it's a fibrous tissue in origin, fat in origin, cartilage, or bone, then we refer to them as the primary descriptor. When we are referring to a benign lesion, we call it as fibroma. If it's fibrous, lipoma if it's fats, chondroma if it's cartilage, and osteoma if it's bone. And we also have the malignant counterpart here, which we would uh, add sarcoma. So for benign lesions, we usually would use the suffix oma. And then when we have the malignant lesions, we add sarcoma or carcinoma. So sarcoma is for mesenchymal origin, okay, or from the vessels, or from the muscle. But if it's epithelial in origin, Benign lesions would still carry the oma, the suffix, cyst adenoma, papilloma. But if it's a malignant counterpart, then we call it as carcinoma. Okay, right? Like renal cell carcinoma, transitional cell carcinoma. There are exceptions to the rule, as some of the malignant lesions would also have a suffix oma in their name. What are examples of this? We have the mesothelioma, we have the melanoma, we have the seminoma. So these are some of the tumors that would have the suffix oma in their names. When we refer to blood cells, there are two types. We have the ones that are located in the bone marrow, and if we are referring to the atypical cells in the bone marrow, we call it as the leukemias. We refer to atypical uh, blood cells in in the lymphoid tissue. We call it as lymphoma. Okay. When we are looking at the muscle tumors, if it's smooth, we add lio, L-E-I-O. If it's skeletal muscle, we add rhabdo. Okay. For epithelial origin, if it's squamous, of course, we just add squamous. For squamous cell papilloma for benign, or squamous cell carcinoma for malignant. If it's a glandular derivation or derivation, then you call it as an adenoma. Okay? And then for placental epithelium, benign would be hydatidiform mole. If it's malignant, we call it as choriocarcinoma. For the germ cell tumor found in the testis, we call it as seminoma or embryonal carcinoma. From the melanocytes, which we would see in the skin, benign would be nevus or nevi if it's multiple. And then we have the malignant melanoma. Then for the neoplastic cell, the tumors that would be derived from uh, one germ cell layer, but would be composed of more than one neoplastic cell type. You have the pleomorphic adenoma because it's a combination of epithelial and myoepithelial cells, and its malignant counterpart would be the malignant mixed tumor. For renal anlage, we have the malignant lesion called the Wilms tumor, which would be seen in children in infants. And this would be a malignant tumor of the kidney. And lastly, we have a type of tumor that would have more than one neoplastic cell type that would be derived from more than one germ cell layer. And if it's benign, we call it as mature teratoma. It's called a dermoid cyst if you do not see uh, you do not see other germ cell layers. Okay, only the skin. So you can call it as dermoid cyst. Immature teratoma would be malignant as well as teratocarcinoma. Okay, so now we look into the comparison between benign and malignant tumors. So how do we differentiate them? So we have criteria for comparison. First, we have the differentiation. It means that they appear to be similar to the mature structures, or they are very atypical that we won't be able to identify that it is derived from its tissue origin. So the benign lesions appear to be well differentiated, while for malignant lesions, they appear to be what they call as anaplastic, or they can also be well differentiated. Right? With regards to the rate of growth, both benign and malignant lesions may possess slowness of growth, especially with the benign lesions. They are slow, they are indolent, okay? And malignant can be slow, can be indolent, but can be erratic. And the presence of mitotic figures is not an indication of malignancy. Take note of that. Because mitotic figures can be an indication of proliferative capacity of that particular tumor. so we can still see them in benign lesions. However, if they are numerous and they possess bizarre mitotic figures, then this would be highly suggestive of a malignant lesion. For local invasion, this would refer to the extension into the adjacent structures. Benign lesions usually do not have invasion. And as a rule, invasion next to metastasis would be a very important significant factor for differentiation between benign and malignant lesion. So if you have invasion, then it's most probably malignant. And metastasis is the most reliable indicator for malignancy. There are some tumors, or rare benign tumors that would exhibit metastasis, like the giant cell tumor, which can metastasize in 4% of cases to the lung. In this illustration, we can see the behavior of the benign tumors and the malignant tumors. The benign tumors are well demarcated, they are small, slow growing, whereas the malignant lesions are poorly demarcated. They tend to be larger than usual. They would present with hemorrhage, the red, and necrosis on the brown. Okay? In order to identify the appearances of the neoplastic cells, we look into the microsections and we identify for the morphologic changes for differentiation, whether they are benign or they are malignant. If they are malignant, are they well differentiated, moderately differentiated, poorly differentiated, or undifferentiated? So let's go over with the different criteria. Number one is pleomorphism. When we talk about pleomorphism, we look into the size and shape of the cell. Is there variation? Are the cells uniform? And then we look into the nuclear morphology, whether they are enlarged or uniform. And we can also use the term pleomorphic for uh, for discussing the size of the nucleus, like pleomorphic nucleus or pleomorphic nuclei. The nuclear features would also show chromatin pattern that can be abnormal because of the DNA content. We call it as hyperchromasia. Some tumors can be hypochromatic, and we call it as vesicular. For mitosis, again, for mitosis, it is seen also in benign conditions. So it's an indicator for cellular proliferation. But if it's numerous, there's a presence of bizarre mitotic figures, then it's highly suggestive of malignancy. Next is loss of polarity. With regards to loss of polarity, we look into the cellular orientation, organization. If there is the presence of sheets growing in disorganized fashion, we call it as loss of polarity. Okay. And dysplasia. Dysplasia would refer to the combination of all the five criteria as mentioned above. We would see presence of pleomorphism, we see the hyperchromasia, we see mitosis, we have loss of polarity, and this is referred to as disorganization of the growth of cells, but it is limited to the basement membrane. And lastly is functionality. Cells who tend to be more differentiated, who mimics the normal structures, tend to be more functional. And the ones that are poorly differentiated, they're the ones that are less functional. It means that they do not carry on the functions of the normal structures. Okay. So now let's go over with the different pictures to differentiate between benign and malignant lesions. So this is a benign lesion, which we would see in the cervix. Because of environmental stimuli, it causes this adaptation, which we would call as adaptation metaplasia. Okay, so in the cervix, we would see the so-called columnar to squamous metaplasia or squamous metaplasia. And or squamous metaplasia if you're going to answer this in the practical exam. And why is it so? Because you would see the presence of the columnar cells with with the cytoplasm possessing abundant mucus, and this would be the endocervical cells. Because of the changes in the environment, you would see the presence of the stratified squamous epithelium. And this is already squamous metaplasia. Is this benign or malignant? Okay. This is not. This is this is an adaptation. This is not a neoplasia. Next, we have the so-called Barrett esophagus. So Barrett esophagus is located in the esophagus. And do you remember the lining epithelium of the esophagus? It is stratified squamous epithelium from the first portion up to the third portion. Okay? So the difference only would be in the muscle, right? Remember? Okay? So what is the problem here? We would see what are these? These are glands. Okay? So the glands, when they are present in the esophagus and replaces the lining epithelium, that form of adaptation is metaplasia. And when you have this particular metaplasia, it's a squamous or squamo to columnar metaplasia, which we would call as Barrett esophagus. And this is because of the presence of hydrochloric acid into the esophagus. Okay, persistence of exposure in gastroesophageal reflux disease. Why is this important? Because metaplastic events can be a risk factor for development of cancers. In this case, if it's found in the esophagus, a person with Barrett esophagus may be at risk for development of adenocarcinoma. By the way, what is the most common malignant tumor found in the esophagus? So you always look at the lining epithelium, which is stratified squamous. So the most common malignant lesion in the esophagus is squamous cell carcinoma, not adenocarcinoma. But because Barrett esophagus is present in our patient, then another another case can be adenocarcinoma. It if it progresses. Okay. So in this particular slide, we would see the presence of normal structures. You have the stratified squamous epithelium, you have the connective tissue, you have the adipose tissue, you have the blood vessels, and then you have the cartilage. So if you're going to look for an area in the body that would possess all this, then you'll be thinking maybe this is coming from the ears because it has a skin, tissue, and then you have the cartilage. But what if I tell you that this particular slide would be derived from an ovarian cyst? Okay, so this is an example of a mature teratoma. Now we are talking about differentiation. So what does differentiation mean? It refers to the extent to which the neoplastic parenchymal cells would resemble the corresponding normal parenchymal cells, or there can be a lack of differentiation, which we would call as anaplasia. So that's differentiation. So it can be well differentiated if they look exactly the same as the mature structures, moderately differentiated if they if some of the structures are similar to mature, and poorly differentiated if most of the cell types are not similar to the cell origin. Okay, so this one is well differentiated because we can readily identify that this is squamous, this is adipose tissue, this is cartilage. In this particular slide, what do you think? What do you think are these cells? These are squamous epithelial cells. And when they are seen in aggregates like this, we call them as nests. Nests like the ones that the birds would form. Nests. So this would refer to the clusters of cells. And how do we know that this is squamous cell, or these are squamous cells? It is identified based on the presence of these concentric lamellations, which we would call as what? Keratin. Okay? And the concentric lamellation here would be called the keratin pearl. So if we're going to look at this particular slide, what do you think? Is this well differentiated, moderately differentiated, or poorly differentiated? Because of the presence of the keratin, we call it as well differentiated. Okay. What if I tell you that this is also squamous cell carcinoma? Do we see the keratinization? No, right? So this is what we term as the poorly differentiated type of squamous cell carcinoma. So if the previous slide would show the presence of keratinization, and you can readily identify, this is squamous cell carcinoma. In this case, if I'm going to give you this one, you won't be able to identify that is squamous cell carcinoma. Okay? And it only happened that I told you that this is squamous cell carcinoma, then you know that this is squamous cell carcinoma. So this is an example of a poorly differentiated type of, tumor. Okay. Now we go into the term pleomorphism. The term pleomorphism would refer to the cell shape and size variation. So the size of the cells, they can be small like this one. They can be big like this one. And this would also refer to the nuclear size and shape. If they are pleomorphic, we call it as nuclear marked pleomorphism, marked nuclear pleomorphism. Okay. You can see the presence of prominence of the nucleolus. Prominence of the nucleolus. Okay. If you would be able to if you would be given this particular slide, notice that the cells here would be very large. What other things that you can see? The cells have multinucleation. The cells have bizarre nuclear figures. Then this is a sign of nuclear pleomorphism. They are bizarre nuclear figures. Then this is malignant. Next slide. So here you would see the presence of mitosis on the left portion. If you see this mitotic figures, these are still normal looking mitotic figures, but they are numerous already. Then you will be thinking most probably this is malignant. Okay, because in one high power field like this, you see already three. What more if you're going to look at the other pictures? But if you would see this one, okay, this particular mitotic figure is bizarre looking. This is not normal. This is abnormal. Then most probably this is malignant. Now we go into polarity. When you say polarity, this would refer to the organization of the cells and maturation of the cells. So in this case, my example would be the stratified squamous epithelium. You can see that the stratified squamous cell or the squamous cells would be arranged in such a way that the maturation would start from the basal layer. So these are the most immature cells. identified with a high nucleocytoplasmic ratio. It means that the most of the cells would contain the nucleus and less of the cytoplasm. And the maturity of the squamous cells would go up, 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 up until they reach the surface. So as they mature, there would be an increase in the cytoplasm, increase in the cytoplasm. And then when they reach on top, take note, the nuclei would tend to be smaller and they would have abundant cytoplasm. Okay. So, so that would be the maturation. That is what you call as polarity. There is organization of the lining epithelium. What about this one? What's what is different from this from the other slide? So you look at the basal layer, as what I have told you in the previous slide. The basal cells are the most immature ones. They have high nucleocytoplasmic ratio, and it should be limited to the basal layer. However, if you're going to compare this particular cell, you compare here, are they the same? Do they have the high nucleocytoplasmic ratio that I'm talking about? So it means that the immature or the atypical cells or the immature cells are not only limited to this particular layer, but also in the upper layer. So it means that there is loss of polarity, loss of polarity. And this is also, in this case, we would see dysplasia. Dysplasia would be a confluence of the features that we would see with pre-malignant lesions and with malignant lesions. What are they? We have the pleomorphism, we have the loss of polarity, mitosis, and hyperchromasia rolled into one. That's dysplasia. So example, you have loss of polarity here. You have presence of mitosis, one, two, three, four. And then you have pleomorphism because of the high NC ratio and hyperchromasia. Okay? So let's look into the other slides. So this is an adenoma. In some tissues, adenomas would would simply mean that there is an increase in the number of glands. Okay, but in the case of the gastrointestinal tract, adenomas always presents with dysplasia. So although they are benign, dysplasias would also always be part of them. Okay, as comparison, the one on the left, this is normal colonic tissue. The one on the right is for the adenoma. So how do you compare them? You look at the lining epithelium, single layer of columnar cells. On the other side, stratification of the nuclei, hyperchromatic. Okay, but this is still benign. Okay. So this is another picture of the glands showing to you the hyperchromatic nuclei. Okay, so hyperchromasia is dependent on the DNA content. Okay, so altogether, what we will see would be dysplasia, combination of pleomorphism, hyperchromasia, loss of polarity, because the atypical cells would not only be located in the basal portion, but also seen in other areas. Sorry. And this is what we call as the carcinoma in situ. Okay, so we have now new terms. Okay, for carcinoma in situ, this is a form of cancer wherein it is limited by the basement membrane. when you call when it has invaded into the stroma, we call it as a local invasion or there's a direct extension. And this is the most reliable feature to differentiate it from malignant and benign next to metastasis. Okay? So metastasis is the most reliable feature. So for metastasis, it means that there's the presence of tumor implants discontinuous with the primary tumor. And there are three pathways of spreading. We have the seeding of body cavities, which we would call as pseudomyxoma peritoneae. And that's an example. And then we have the lymphatic spreading, which would mean that it would disseminate through lymph node involvement. And skip metastasis may occur. It means that it is seen because of the destruction resulting to venous to lymphatic anastomosis. And a biopsy of the sentinel node is used to assess for the presence or absence of a metastatic lesion in the lymph node. So what do you mean by sentinel node? Sentinel node is defined as the first node in the regional lymphatic basin that receives the lymph flow from the primary tumor. Okay. And then we have the hematogenous spreading. The most common sites would be the liver and the lung. The vertebrae can be a common metastatic site for the thyroid in the prostate cancers because of the accessibility to the paravertebral plexus. That's what we call as the Batson's plexus. Okay, so when you hear the term Batson's plexus in the conference, then most probably this would be coming from the thyroid or from the prostate. Now let's look into the gross appearance of the benign tumors. This is a leiomyoma. This is a uterine. This is the uterus, the cervix, the ovaries. You can see the presence of nodules. These are tumors, which we would call as leiomyoma. And these are benign tumors. This is from the gastrointestinal tract. And you can see the presence of what we call as the polyps. Polyps are referred to as the pedunculations. It can or sessile formations of tumors, and it can be benign or malignant. You can see there's a lot of these polyps in this particular patient. Going back to the term carcinoma in situ, when we have carcinoma in situ, it means that we have the presence of these plastic features, but more of the malignant side, which would mean that you see bizarre mitotic figures, presence of very pleomorphic nuclei, and the atypical cells would be up to the surface. And this is carcinoma in situ. But if you would see the presence of an extension of the atypical cells into the stroma, this is what we call as already a microinvasive carcinoma. So the invasive carcinomas or sarcomas can be seen invading or infiltrating into the stroma like this. And they can appear to be forming nests, or in this case, these are glands. So this is adenocarcinoma. Tumors grossly can appear to be like this one. Okay, so they have a central ulceration. They have this hipped up borders, and these patients may think that this may be benign. I'm not going to the doctor. Okay, but there are cases wherein you would see this type of lesion, wherein initially our patients would be in a denial, and then they just come to us if it's very, very big already, to the point that we have to do uh, some wide resection just to remove the tumor like this. Okay, so this is an example of a local invasion. Like a squamous cell carcinoma, it tends to invade locally like this. Okay, so extend to the next tissue, adjacent tissue, extend until such time it becomes very big. In this particular slide, you would see a cyst. In this particular cyst would contain the mucus content. So this can be a mucocyst. There are some cases wherein the cysts, although they are benign, they have the tendency to rupture because they are cysts. And they then would go into the peritoneal cavity, be released into those areas and cause adhesions. So this is an example of a metastatic spread, which we will call as seeding into the cavities. And this is what we call as the pseudomyxoma peritoneae. Okay. The lymph nodes can be affected or can be involved. Um, the enlargement of the nodes can be due to the involvement of the cancer with the presence of cancer cells like this, or it can be associated with a reactive hyperplasia. So not all lymph nodes, when we are going to palpate for them, would be malignant automatically. So we still would have to look at the microsections for identification of malignancy. So what do we see here? We have the vascular channel containing a tumor nest. This is a vascular channel containing tumor nest. So this is a sign of hematogenous spreading. So microscopically, we also have to look for lymphovascular invasion. Okay. So by hematogenous spreading, the two most common sites, what are they? We have the liver and we have the lung. Okay. Our dictum would be if the nodules are multiple in the lung or the liver, then think of metastatic. If it's solitary, it may be primary. However, there are cases wherein there's an overlap of this dictum. Okay, but most of the time, that dictum applies. Okay, wherein if it's multiple, it's metastatic. If it's solitary, it's primary. Okay. Hematogenous spreading can also lead to the formation of tumor emboli that can lead to infarction. Like in this case, this is from the aorta, that the tumor embolus would be lodged into the renal artery. By cancer incidence, this is in 2014, you can see that reproductive organs are the most common sites for malignancy. In the men, it's a prostate. For females, it's a breast. Followed by the lung, and then the colon and the rectum. In developing nations, the lung would be the most common, followed by the stomach and the liver in men. And for females, it's the breast, followed by the cervix and the lung. By cancer deaths, the most common would be the lung, okay, for both males and females, followed by the reproductive organs, as the prostate and the breast, and followed by the colon and the rectum. Environmental factors would play an important role in the formation of cancers. 15% of tumors would be associated with infectious agents, okay, like the presence of liver flukes that can cause cholangiocarcinoma, Helicobacter pylori, which would cause gastric adenocarcinoma, or this is MALT, mucosa-associated lymphoid tumors. Hepatitis B or C would be associated with hepatocellular carcinomas. Epstein-Barr virus, the so-called EBV, would be associated with the formation of Hodgkin's lymphoma, non-Hodgkin's lymphoma, and even undifferentiated carcinomas of the nasopharynx. We have the human herpes virus type 8 that would cause Kaposi sarcoma. We have schistosoma hematobium that would cause the bladder cancer. And then exposure of the female genital tract to human papillomavirus, to chlamydia, gonorrhea, can can lead to cancer. Okay. Next, we have the smoking. Smoking has been implicated in a lot of cancers: lung, esophagus, pancreas, oropharynx, larynx, in the bladder. Alcohol consumption would be associated with hepatocellular carcinoma, with carcinoma of the esophagus, larynx, and oropharynx. Diet, the differences in the world would cause a variation in the incidence of cancer. Like here in the Philippines, it would be similar to United States because we are eating westernized food like steak, like hamburgers, and so on and so forth. In Japan, they are fond of eating raw food like sushi. Then the type of cancer that would be associated with them would be more of stomach. Obesity has been implicated in increasing the risk for malignancy. For reproductive history, uh, the presence of hormonal stimulation like estrogen can lead to hyperplasia and carcinomas. And lastly, for environmental carcinogens, uh, the food that we eat, there's a lot of chemicals. Exposure to the ultraviolet light, smoke from our vehicles, use of medications, exposure to chemicals like paints or other forms of chemicals at work, the like um, or at home. The one I'm exposed to would be formalin. Okay, can be uh, factors that would lead to carcinogenesis. Okay, so these are occupational cancers that are associated with agents that can be seen in the workplace. Arsenic is known as a poison. If we are going to look into environmental pathology, it is used as a component for alloys. Asbestos was used in existing construction materials and is identified with mesothelioma. Benzene can be associated with dry cleaning, with adhesives, and is associated with myeloid leukemia. Metals like beryllium, cadmium, chromium, nickel. Okay, so these are metals that can lead to their specific types of cancers. Okay, and then we have the radon, which is it's a radioactive material which can be seen in caves, in quarries, underground mines. Um, it can be a risk factor for lung cancer. And vinyl chloride would be, which is used as a refrigerant, adhesive for plastics. But if you are working uh, in those plants, there's increased risk for angiosarcoma. These tabulations would refer to the leading cause of deaths for males and females. Okay, this is in 2000. So I just want uh, to tell you that age is a factor with regards to the type of tumor that would be present. For uh, for patients that are less than 40, usually the tumors are small and round. Okay, small round cell tumors like leukemia, like lymphoma. Okay, from the brain they can be medulloblastomas. So they are small and round. However, as we age, if you are more than 40, because of the stress, because of the exposure to a lot of chemicals and environmental factors, there's a lot of somatic mutations that would occur. And this time, age 40 and above, the cancers that we would see in our patients would be more of somatic mutations, like breast cancers, lung cancer, colon cancers, and so on and so forth. You know. Next, we have the acquired predisposing conditions like chronic inflammation. Uh, we have uh, in the book, you have the different chronic inflammatory states. Okay, we have the IBD, inflammatory bowel disease, which is autoimmune, and it can lead to colorectal carcinomas. Lichen sclerosus, okay, would be associated with squamous cell carcinoma. We have the reflux esophagitis, which is associated with adenocarcinoma of the esophagus. Autoimmune disorders like Sjogren syndrome, Hashimoto's thyroiditis can be a risk factor for mucosa-associated lymphoid tissue lymphoma. And then we have the Helicobacter pylori, which is associated with the formation of ulcers and gastritis, but can also be associated with gastric adenocarcinoma and maltoma. Hepatitis B and C would be, of course, associated with hepatocellular carcinoma. HPV or human papilloma virus would be associated with cervical carcinomas or squamous cell carcinomas. And then schistosoma hematobium would be associated with bladder cancer. Precursor lesions would also be a significant factor. Okay, so these are the metaplastic conditions like the Barrett esophagus with gastroesophageal reflux disease, with bronchial squamous metaplasia if our patients are smoking a lot, gastric intestinal metaplasia if they have history of H. pylori infection, bladder squamous metaplasia. What happens here? If there's exposure to schistosoma hematobium, endometrial hyperplasia, patients with um, patients with estrogen stimulation, and then villus adenoma can be associated with mutation. And immunodeficiency states would be at risk for development of cancer. With regards to inherited predisposition of cancer, it means that some of our patients would already be carrying a germline mutation. It means that this has been given to them by one of their parents. Okay, and a gene usually has two alleles. If you already have one mutated gene, you only need another to cause uh, a genetic mutation that would lead to cancer. So these are examples of the inherited genes. The RB, which would lead to retinoblastoma. P53, which take note that uh, this genetic mutation would only present with a single allele. Okay, so we have the Li-Fraumeni syndrome, P16INK4A. If it will lead to malignancy, it will be melanoma. We have the APC. If they only have one, then it's a familial adenomatous polyposis. But if they have two, this is already colon cancer. NF1, NF2, neurofibromatosis. You have the BRCA1-2 for breast and ovarian. Okay, and so on and so forth. MSH2 for hereditary non-polyposis colon cancer. Okay, so these are some of the inherited conditions, and we will look into them when we go into the second part. Okay, so thank you for listening and good day to everyone.